Hello, my name is Gwendolyn Kukel, and welcome to this presentation. Today, I'll be presenting my research proposal titled Peer Recovery Specialists and Trauma-Informed Practice, Implications for Recovery Outcomes in Residential Care. This proposal explores how trauma-informed training among peer recovery staff impacts overall quality of care, particularly client engagement, emotional safety, and long-term recovery outcomes for individuals who are living with co-occurring mental health and substance use disorders. Throughout this presentation, I will review the problem, talk about the current research, make some ethical considerations and recommendations for improving peer support services in residential treatment settings. Before we jump into our study proposal, let's take a minute to look at what is defined as a peer support specialist. And there are many variations of the term: peer worker, peer specialist, peer recovery specialist, peer coach, and so forth. But I will be using the term peer recovery specialist, or PRS, throughout this presentation. According to SAMHSA's core competencies for peer workers in behavioral health services, a peer worker is someone with lived experience of recovery who provides non-clinical, person-centered support grounded in mutual respect and shared experience. Their role is non-clinical and focuses on empowerment, trust, and collaboration. They support recovery by sharing tools, listening empathetically, and helping others define what wellness looks like for them. Peer workers should be operating within that trauma-informed and person-centered frameworks, which means they prioritize safety, respect, and individual choice. However, it's equally important to clarify what peer workers do not do. They're not clinicians or therapists. They do not diagnose, and they do not control treatment plans. And there are other things they cannot do, but their role simply is to complement rather than replacing professional care. So having defined what a peer recovery specialist is, let's move on to our identified problem statement for this proposal. According to SAMHSA, PRSs must operate within clear competencies, but the problem lies in growing gaps between what they can and cannot do in practice. For example, in my state of Colorado, many residential treatment programs have begun implementing more PRSs due to a shortage of licensed or certified addiction counselors. And while it makes sense to utilize staff with lived experience to help relieve the overworked therapists and counselors, most programs only provide a brief orientation or basic peer support training and often rely on their personal experience as the main qualification for working with clients. So I see the problem is this: because of staff shortages, PRSs are often asked to provide levels of emotional support, case management, and even therapeutic interventions that extend beyond their scope of training or certification. So when staff lack that formal evidence-based trauma-informed education, it can lead to negative consequences for clients, the peer themselves, and the agency. Without proper training, PRSs may unintentionally reinforce power imbalances or re-traumatize vulnerable clients. As rates of co-occurring mental health and substance use disorders continue to rise, the need for formal trauma-informed frameworks has become increasingly urgent, especially for those in PRS roles. So this led me to my important research question. How does the absence of formal trauma-informed training among peer recovery specialists in residential treatment programs for clients with co-occurring mental health and substance use disorders impact client satisfaction, treatment retention, and recovery outcomes? The research shows and really does highlight that insufficient training and organizational support can lead to burnout, blurred boundaries, and inconsistent service quality. Similarly, there is an emphasis that successful peer support integration requires structured training and organizational commitment. Despite these findings, there remains a lack of research directly measuring how missing trauma-informed training impacts outcomes such as retention, relapse rates, and client satisfaction. So as I began researching this problem topic, several common themes emerged from the sources. I researched those sources on the left. First, trauma-informed training is essential for safe and effective peer support. Second, peer support enhances client trust, engagement, and empowerment. Third, organizational buy-in, such as policies, supervision, and culture, is critical. Fourth, gaps in training can lead to staff burnout and inconsistent service delivery. So I'm going to go back to what is notably lacking in the literature. There are studies that directly assess the measurable. There are no studies, that directly assess the measurable effects of it or impacts of missing trauma-informed training on treatment outcomes such as the retention, relapse rates, and client satisfaction. And here you can see through this upside down triangle here at the micro level, research should explore how the absence of trauma-informed approaches influence individual client experiences of safety and trust. At the meso level, this includes examining how organizational culture or supervision and staff training policies affect program consistency and staff-client dynamics. And finally, at the macro level, there is limited investigation into how systemic inequalities such as funding disparities and workforce shortages contribute to the ongoing gap in trauma-informed service delivery within the residential treatment settings. So this reminds us that effective peer support requires attention at all levels of practice, the micro, the meso, and the macro, like funding and workforce strategies or shortages. Since our research question focused on the impact of peer staff lacking trauma-informed training, we aim to explore how organizational, interpersonal, and systemic factors influence client-staff interactions and affect satisfaction, engagement, retention, and recovery outcomes. This study will be led by systems theory, which investigates interconnected aspects such as organizational structures, interpersonal dynamics, and larger systemic implications on staff-client interactions. It is also important to follow the trauma-informed care framework set out by SAMHSA. It's in tip, I believe it's 57, titled Trauma-Informed Care in Behavioral Health Services, which highlights fundamental elements for effective care, including safety, trustworthiness, peer support, teamwork, empowerment, and cultural sensitivity. This paradigm provides a comprehensive perspective for assessing how trauma-informed principles or their absence influence service delivery, client involvement, and overall recovery success in these residential treatment programs. And I think together, these provide a lens for understanding how the presence or absence of trauma-informed practices affects client outcomes and staff experiences. So let's look at the methodology. The study will use a mixed methods approach, combining quantitative data such as satisfaction and completion rates with qualitative insights from interviews. Because this study will use both quantitative and qualitative data, a mixed methods approach will be applied to ensure a comprehensive understanding of the relationship between trauma-informed training and treatment outcomes. It is also important to measure additional training data such as cultural diversity, ethics, boundaries, and confidentiality. This design allows us to measure tangible outcomes while capturing the lived experiences of both clients and the peer specialist. This can all be analyzed using a statistical package for the social services software. And I'll talk more about that on this next slide. Let's take a closer look at that data analysis. It is important to use client satisfaction surveys, retention statistics, and treatment completion rates for the quantitative data and analyzed using that SSPS or SPSS software, which will allow for calculating descriptive statistics such as means and frequencies, and conducting inferential tests using, for example, t-tests or ANOVA to examine relationships between staff training and client outcomes. On the qualitative data side, which would be gathered through staff and client interviews. The data would be coded manually to identify reoccurring themes related to emotional safety, trust, and engagement. This approach was chosen because it reflects the person and environment perspective of social work, allowing for both measurable analysis and insight into human experiences. A single method design was rejected because it would fail to capture either the statistical trends or the relational depth necessary to understand trauma-informed care. According to SAMHSA, trauma-informed care is essential because it requires organization to build staff competence, establish clear clinical standards, and ensure service delivery through a trauma-insensitive lens. This includes recruiting and retaining skilled staff, engaging trauma survivors and peer specialists in program development, and fostering collaboration across service systems while maintaining a continuity of care as clients transition between services. This research is important because it examines what happens when these trauma-informed principles are absent, highlighting how the lack of structured TIC training can negatively affect client safety, engagement, and recovery outcomes in residential treatment settings. It also puts a spotlight on the efforts on the effects of the peer support specialists themselves, who may still be in their recovery process and not have the necessary tools to effectively support clients in a trauma-informed manner. In some of the research that I was looking at, they emphasized that peer support programs are most effective when organizations create culturally inclusive environments that value diverse perspectives and experiences. They state that organizational culture and inclusion are critical when implementing peer support roles in co-occurring treatment settings. Diverse clients, particularly women, LGBTQIA+ individuals, and racial minorities, often report distrust or re-traumatization in treatment due to lack of cultural awareness among staff. If residential co-occurring facilities are going to have peer specialists on their staff, these staff should be embedded with cultural competency training, anti-oppressive practices, and knowledge of ethics and equity principles to ensure safety for themselves, the clients, and the agency. Any research with individuals who have trauma and substance use histories requires strict adherence to ethical principles to protect participants' dignity and autonomy. And here I have on here a reference to the NASW Code of Ethics, which guides this research through the values of service, dignity and worth, integrity, social justice, and cultural humility. The study includes clients and peer specialists who may have experienced trauma, discrimination, or oppression. To reduce re-traumatization, researchers will use trauma-informed practices, clear informed consent, confidentiality, voluntary participation, sensitive interview questions, and debriefing afterwards. The ethical safeguards also ensure cultural humility and non-discrimination, addressing those power imbalances and respecting those diverse voices. Integrity will guide data collection and reporting with findings presented honestly and accurately. Aligning with those NASW values ensures the study models those ethical, trauma-informed research that supports equitable care. Okay, as I reviewed the research and examined those gaps in trauma-informed training among peer specialists, several key recommendations emerged to strengthen the quality of care for clients with co-occurring disorders and trauma histories. And I'll just go through these kind of quickly. First, residential treatment facilities should be required to provide evidence-based trauma-informed training for all staff, particularly peer specialists, as a condition for licensure or funding. This ensures that trauma-informed principles aren't optional, but foundational to program delivery and safety. I don't believe that having someone hired on as a peer support specialist without these licensures or these evidence-based trauma-informed training is doing our clients any justice. So this is a big one for me. Second, it's critical that staff receive ongoing supervision and structured self-care support. Peer specialists, many of whom have lived experience, face unique emotional demands that can lead to burnout or relapse without consistent supervision and mentorship. This is a big one as well. Third, programs should integrate client feedback loops on a consistent basis, such as satisfaction surveys, exit interviews, or peer-led focus groups to continuously evaluate how safe, inclusive, and effective trauma-informed practices truly are from the client's perspective. Finally, there's a broader need to advocate for policy-level change. Funding and regulation should prioritize equitable trauma-informed systems of care, whether they're occurring diagnosis center or not, especially for those marginalized populations who are often most affected by the lack of culturally competent and trauma-sensitive treatment environments. And I think together these recommendations move beyond individual level interventions to strengthen organizations, promote accountability, and to ensure that both staff and clients are supported within a truly trauma-informed system of care. And that wraps it up for my presentation. These just last two slides go over some of the resources presented in this presentation. I want to thank you very much for your time, and I will see you again soon.